My dad works in B2B marketing. He came by my school for career day and said he was a big ROAS man. Then he told everyone how much he loved calculating his return on ad spend. My friends still laugh at me to this day.
Not everyone gets B2B, but with LinkedIn, you'll be able to reach people who do. Get a $100 credit on your next ad campaign. Go to linkedin.com/results to claim your credit. That's linkedin.com/results. Terms and conditions apply. LinkedIn, the place to be, to be.
This is the number one killer of women. This kills more women than breast cancer and all of the other cancers combined, added to breast cancer, and this is still number one. That's the message that doesn't get out. And so women are underdiagnosed, misdiagnosed, misrepresented because our symptoms can be different.
Welcome to the No Guilt Mom podcast. I'm your host, Joanne Crone.
With the bobblehead Bree here. I'm just like bopping. I'm bopping.
See, do you see how
Yes,
I'm totally
indeed.
out of it, Bree, because I totally forgot my intro.
It's okay. Joanne was feeling a little under the weather today. So
Under the
we
weather.
thought,
I'm
what?
so scared about getting sick, too. I was so scared about it.
Why are you scared about getting sick right now?
Because we go to Vegas next week. Guys, we're going to a huge conference next week in Vegas. It's me and Bree and Christina on our team. It is going to be such a fun time, and I don't want to be sick for it. But then again, many sicknesses don't last a week, so maybe it's the right time to get sick.
Yeah, that's what I'm thinking. I'm like, well, actually, let's get sick today.
Today, yeah.
Then, I don't know, like the
Next
day
Monday?
before we leave.
Before we leave. Yeah, that would
Or
be
the
awful.
day we leave. Oh, God, do not. Oh, I don't want to be on the plane.
I won't get sick the day before we leave because I'm getting sick right now.
Okay.
It's like with all this stuff going around. But we actually have a really great treat for you because our Happy Mom Summit is open for registration right now. And we're going to show you some of the great stuff in our summit, featuring an interview from Dr. Jayne Morgan, where you can see it all in the summit. And Bree, this was one of our favorite interviews.
Yes. And the reason it was one of my favorites is if you've been listening to the podcast, you've heard me talking about my lovely annoyance with perimenopause. And so Dr. Jayne was recommended to us by several people. And oh my gosh, the things I mean, I knew about my like itchy ears, lack of sleep, sweats, mood disorders, whatever. But I did not know that by just living with the symptoms, I could be causing irreparable health damage to myself.
I know this conversation I had with Dr. Jayne, it has changed my opinion on so many things, like hormone replacement theory, totally changed my opinion on that. And one of the facts she shares about how medical trials are done, jaw on the floor. I tell everybody in my life, I'm like, do you know how they're done? Now you're going to be in the know as well. So we hope you enjoy our Happy Mom Summit interview with Dr. Jayne Morgan.
You want mom life to be easier. That's our goal too. Our mission is to raise more self-sufficient and independent kids, and we're going to have fun doing it. We're going to help you delegate and step back. Each episode will tackle strategies for positive discipline, making our kids more responsible and making our lives better in the process. Welcome to the No Guilt Mom podcast.
Hey, I'm Joanne Crone, and I'm so excited to introduce you to the incredible Dr. Jayne Morgan. Dr. Jayne is an accomplished cardiologist and the Vice President of Medical Affairs for Hello Heart, where she has a focus on women's health and AI. With both an interest in menopause and women's well-being, Dr. Morgan was recently named by Midi Health to the 45 over 45 list of top women's health experts and to Atlanta's top most powerful leaders in 2024. And with that, welcome, Dr. Jayne.
Thank you, Joanne. I appreciate it. I'm looking forward to being here.
I am excited to have you here because like when we did our pre-interview, you told me some pretty like shocking revelations for me that I didn't even know was going on in the women's healthcare industry. Yeah. And so I'm excited to get into it with you, but let's start broad. Okay. What obstacles are women facing right now in general regarding taking care of their own health?
I think most of the obstacles have to do with really access to care, meaning even though you're making an appointment with your physician and you may be showing up and you may be doing your regular physicals, access means, are you being included in clinical trials? Does your doctor actually treat you based on data that's been submitted to the FDA that may or may not have had any relevance to you or not? And so in some ways, we're all in this big experiment together, because the drugs and the devices that we have today on the market, and even yesterday on the market and the day before that, really are all developed on data that comes from men who are enrolled in these trials. And then we sort of extrapolate it to everyone else. I call it the big extrapolation. So as a physician, we might see a woman come into our office who may be small framed, and we will just make an adjustment to the medication that's completely non-scientific, but we will say, oh, you know what, I'm going to give you just a little bit less, even though that's not what the FDA approved, because we know that they approved the data on 70-kilo men. That's an average weight. And now we've got this small framed woman in front of us. And so this is just nonsense to practice medicine this way. It's just a guesstimate. And then the same thing for all other non-white populations. We just kind of extrapolate it to the rest of the world. We just throw it out there, and then we kind of see what happens. And so that's what I spend time working on.
Yeah, that is crazy to me. And I know we're going to get more into that a little bit later. But what mistakes do you think women are making right now in terms of their own healthcare? What would you suggest people do differently?
I think some of the things that we need to do differently, and maybe we'll get into it later, is to really understand our connection to heart disease, and that heart disease is the number one killer of women. It's not breast cancer. It's not something else that you may think. And even though breast cancer gets a lot of attention, and deservedly so, it's not the number one killer of women. Not only is heart disease the number one killer of women, it kills more women than breast cancer and all of the other cancers combined, added to breast cancer, and heart disease is still number one. That's the message that doesn't get out. By and large, people are still looking at heart disease as a disease of men. And guess what? It's never been a disease of men. But because men were enrolled in these trials, this is what we considered it to be. And so women have been done a great disservice. We generally are underdiagnosed, misdiagnosed, misrepresented, because our symptoms can be different as well. And so this is really a message that I really strive to make certain that people understand, and that you can advocate for yourselves and be able to maneuver a system that can be complex, especially if the data has not been generated on you, it has not been generated for you.
Oh my goodness. Okay. If anyone was watching my eyes when Dr. Jayne was talking, I'm like, what in the world? Why have we not been told this? So we're going to get into those three shocking things a little more in depth. And one she hasn't even mentioned yet. So get ready, because if you are in a perimenopause stage, this applies to you.
That's right.
The first one you mentioned, how women are recruited into trials, how women's care is related to the medical trials and representation.
How we are not recruited into trials.
We'll be right back after a quick break.
I'm starting to look more closely at what's in the things I use every day, because you want your house clean. You don't want to spray around microplastics and wake up with hives. That's why I was really excited to try Branch Basics.
The Branch Basics Premium Starter Kit includes one powerful concentrate that replaces traditional cleaning products.
I mean, one product that then goes into all different bottles and different concentrations for your counters, for your laundry, for your windows, everything. This formula does it all.
The Branch Basics Concentrate replaces dozens of cleaners you're now using with something that's free of fragrances, thank you, free of parabens, love that, and free of synthetic preservatives, so you can trust it's safe for everyone in your home.
Branch Basics means less plastic waste, fewer toxins, more clean. Make this year the year you say goodbye to toxic products. Right now, our listeners get 15% off the Premium Starter Kit by using code FRESH at branchbasics.com.
That's 15% off your new Branch Basics Premium Starter Kit at branchbasics.com with promo code FRESH. Make 2025 your cleanest, healthiest year yet with Branch Basics.
Building a portfolio with Fidelity Basket Portfolios is kind of like making a sandwich. It's as simple as picking your stocks and ETFs, sort of like your meats and other toppings, and managing it as one big, juicy investment. Now that's pretty good. Learn more at fidelity.com/baskets. Investing involves risk, including risk of loss. Fidelity Brokerage Services, LLC. Member NYSE SIPC.
I think I just won my taxes.
Yeah?
I just switched to H&R Block in about 1 minute. All I had to do was drag and drop last year's return into H&R Block, and bam, my information is automatically there.
So I don't have to go digging around for all my old papers to switch?
Nope.
Sounds like we just leveled up our tax game.
Switching to H&R Block is easy. Just drag and drop your last return. It's better with Block.
So if you are in the perimenopause stage, this applies to you. The first one you mentioned, how women are recruited into trials, how women's care is related to the medical trials and representation.
How we are not recruited.
We're not recruited. Okay, tell me more about that.
Yeah. And so, here's how we get drugs and medications and devices to the market. We actually do clinical trials and we recruit people in, and then we follow them over a period of time. We get all the data and we get that data to the FDA, and the FDA, this is a very simplified version. FDA says yay or nay. Well, that data, by and large, is generated on men. The principal investigators, meaning the physicians that lead these trials, are also men. We know that people are more likely to participate in trials if they are approached by their physician. And so physicians tend to approach like people as well. And so we have an entire system, not just here in the United States. The United States actually feeds medicines to the rest of the world. And so there's a global population that's really built on a very, very narrow slice of the population. And that's one of the things that we need to begin to understand and guard against. Why? It's very important. We don't know anything about pregnancy during these medications. We don't know what's happening to our menstrual cycle. If you're in perimenopause and menopause, you have estrogen levels that are dropping, progesterone levels that are dropping. Is the medication giving you the same effects? Or are you having deleterious effects? Are you having interactions now at 50 that you may not have had at 30, but since you weren't included in any clinical trials and nobody thought to think about menopause or perimenopause or pregnancy or menstrual cycles, it's all just kind of a little bit of a crapshoot when we take these medications. And that is really the travesty. And that's what I speak up about quite a bit in lobbying people and legislators and really speaking up for women's health.
So you said that a lot of the people are recruited into medical trials by their physicians and like recruits like. Are you seeing any changes in the representation in physicians, like the people coming out of medical school, that we could hope this will change in the future?
And so physicians, it's a great question. Physicians don't translate to these PI, principal investigators. Okay. So physicians are recruited to become the principal investigators. These are leaders of the trials, but it's a very narrow, very small slice. Most physicians that are practicing are not principal investigators. So generally, these types of physicians have a little bit more of a leaning towards research, a little bit more of a leaning towards academics, and generally have relationships with these companies, and then are sort of curated and brought in. Now, that means, again, that the drug companies, who are by and large led by men, generally white men, recruit sort of similar things. And now we get to the fact that these people are seeing patients and they recruit similar things. And you can see how it just starts to beget on itself, one thing after the next. Yeah. The good thing is in medical school, so I'll get back to your question, in medical school, we have more and more and more and more women now in medical school. And in fact, some medical schools have more than 50% of their class as women for the first time. So this is quite exciting.
That is exciting.
So the pool that is coming, there's a larger pool from which to select. as well. And then the other thing to think about with women physicians, and if you ever follow me on Instagram, I talked about this last week because the New York Times actually published an article, and it was about women physicians and how they generally have about an hour less free time than their husbands, even though there may be shared housework, but the females tend to still take the lion's share of that unpredictable work. So childcare, making meals for other people. So you're on other people's schedules, as opposed to men tend to do the kinds of work that they can plan, right, around their exercise. So mowing the lawn and trimming the hedges and making repairs around the house. Those are kind of solo activities. The kids are not interrupting them. They're not on anyone's schedule, and they can just kind of craft it around their exercise schedule. And so women tend to get about an hour less of exercise or free time to exercise. And that's important because the habits that we form early have an effect on what our heart health is going to be later, especially during perimenopause and menopause. And men have an advantage in being able to keep their hearts healthy because they have less home responsibilities, even when both people are working and even when both people are sharing the housework.
Man, so the mental load, we talk about the mental load a lot here at No Guilt Mom and a lot through the Happy Mom Summit as well. So not only does it have an effect on our mental state, but you're saying it has an effect on our physical state as well.
On your physical state.
And I'm guessing that it also has an effect on why heart disease may be the number one killer of women, which is the second shocking thing.
That's right. And heart disease just marches on. Absolutely. Heart disease marches on. We have less time to take care of ourselves. We generally put others before ourselves. We don't put ourselves first. Men are sort of the opposite. They put themselves first. You have to remind them that there are, other people they possibly need to consider. Women are the opposite. And so what happens is long term, even though women outlive men generally by about 6 years, we also spend about 25% more of our lives in poorer health than men. So we have quantity, but we lack the quality, especially in our later years as we go through menopause and perimenopause, and we don't have information. And that's a time when your heart disease risk also further increases.
Knowing that heart disease is the number one killer of women, what could women be doing differently to help prevent heart disease in their life?
So for everyone who's ever been pregnant, ever had a child, if you've ever had any complications of pregnancy, so for instance, hypertension of pregnancy, gestational diabetes, preeclampsia, eclampsia, if any of these terms are familiar to you, you should have been followed by a multidisciplinary medical team that included not only your OB-GYN and your high-risk OB, but also a cardiologist should have been embedded in that team. The reason for that is if you've developed any of those complications during your pregnancy, from an obstetrician perspective, this is why it's good to have different perspectives, diverse perspectives at the table. The obstetrician looks at that patient and says, here's a 32-year-old pregnant female with preeclampsia. A cardiologist looks at that person and says, here's a 32-year-old volume overloaded female who has just failed her stress test. Any pregnancy that develops those complications is a failed stress test. A pregnancy itself is a volume overload for the system and for the heart. So you can see how a different lens then drives different medical workups. And like anybody who's failed a stress test and they referred to me or any other cardiologist, you're going to go on to have a further workup. But that's not what happens because the only lens that's on that patient is the lens of the obstetrician, and the obstetrician is not viewing that patient from a cardiac lens. And so the treatment is to deliver the baby, because after the baby is delivered and the baby is healthy, all of those symptoms then go away by and large of the mom, and we all applaud and congratulate ourselves and it was another save. But the fact of the matter is we know now that those symptoms actually were markers for long-term heart disease for that woman, and she should be referred to a cardiologist, not just referred, have a warm handoff, and not just a warm handoff. Cardiologist should have been involved during that pregnancy as well. Not only is your risk increased, your risk is now twice that of the normal population of having a heart attack just from that pregnancy. The pregnancy didn't cause it, the pregnancy declared it.
That is so interesting to know because hi, I'm a high blood pressure person who had high blood pressure during pregnancy, and I was just told to wait alone in the room for my blood pressure to go down. We'll be right back after a quick break.
You know what's smart? Enjoying a fresh gourmet meal at home that you didn't have to cook. Meet Factor, your loophole in the laws of mealtime. Chef-crafted meals delivered with a tap, ready in just 2 minutes. You know what's even smarter? Treating yourself without cheating your goals. Factor is dietitian approved, chef prepared, and you plated. Pretty smart, huh? Refresh your routine and eat smart with Factor. Learn more at factormeals.com.
We're so done with New Year, New You. This year, it's more you on Bumble. More of you shamelessly sending playlists, especially that one filled with show tunes. More of you finding Geminis because you know you always like them. More of you dating with intention because you know what you want. And you know what? We love that for you. Someone else will too. Be more you this year and find them on Bumble.
Are you a parent in need of a laugh and a little escape? Look no further. Parenting is a Joke is the podcast you've been waiting for. Hey, I'm Ophira Eisenberg. I'm a stand-up comic and parent. And each week I chat with one of my top comedian pals who, just like you, are juggling careers, busy lives and schedules, and raising a family. You can expect candid stories, hilarious mishaps that happen on stage and at home, and just a lot of laughs. There's no expert advice here. Well, actually, sometimes a good idea does sneak its way in, but mostly just pure, relatable fun to remind you that we're all in this parenting adventure together. New episodes of Parenting is a Joke drop every Tuesday, so tune in, get ready to laugh, unwind, and maybe even feel a little bit better about your own parenting. Because sometimes that's exactly what your therapist, pediatrician, and bartender ordered. Subscribe now on your favorite podcast platform.
That is so interesting to know because hi, I'm a high blood pressure person who had high blood pressure during pregnancy, and I was just told to wait alone in the room for my blood pressure to go down because every time I walked into the obstetrician's office, I was freaked out and had no follow-up after that whatsoever.
Well, that may have been a little bit of white coat syndrome if your pressure was going up whenever you walk into the office and all the white coats, or if you had high blood pressure before your pregnancy even began, but they both can be risk factors. What I'm talking about is you don't have high blood pressure when you're pregnant, but by the time you are at 20 weeks of gestation, you have developed high blood pressure, or you've developed diabetes, or you've developed some of these in-organ issues, meaning that your kidneys might start to be affected, or your liver might start to be affected by this high blood pressure. So those are the kinds of things. And it's not as uncommon as you think. 3 to 7% of women have these complications. That's a large percentage of women who then go home without any cardiology follow-up.
Yeah, that is so interesting. If women have had those kind of symptoms during their pregnancy, do you recommend they ask to be referred to a cardiologist, or is just a general practitioner enough?
No,
it has to be a cardiologist to look through with that lens.
It needs to be a cardiologist. Now, the cardiologist can, after you see she or he, and you all have done your workup and established your baseline, and they determine that you're stable or you're on stable medications, then you can be transferred back to your primary care physician, but absolutely not. You need to see a cardiologist, not a primary care physician. I want to be clear about that. Your risk of heart disease is increased, and a cardiologist, first of all, should have been embedded in your team when you were pregnant. But if that didn't happen, someone needs to see you. You need to have that relationship.
That is good info to know and a great thing to do to be proactive about your health for the future. Let's get into perimenopause. This is something that like me and my friends talk a lot about. Like I'm 43, we're in that age.
Right.
What are some symptoms that like aren't really talked about perimenopause?
Right. And so what is perimenopause? Perimenopause is that time before you're entering menopause, but you are approaching it. And menopause is, by definition, when you've gone an entire 12 months, uninterrupted 12 months without any menstrual cycle at all.
Mm-hmm.
So it doesn't count if your menstrual cycles are irregular for 12 months. It doesn't count. You have to go 12 months without any bleeding at all. And that's when you're in menopause. So all those years leading up to it, starting at about 35 years of age, are really perimenopausal years. And women go into it at different rates. And during that period of time, your estrogen levels are slowly decreasing, as well as progesterone and even testosterone. Here's something we don't realize. Women actually have more testosterone in our bodies than we have estrogen. And that testosterone is important because it maintains our muscle mass and bone health as we get older. It prevents that frailty and those falls and those fractures. So all of this is important as we go through this stage in our lives. So it can start as early as 35. Here's the fun fact. You can actually be in perimenopause, but also still be ovulating and still be at risk of getting pregnant. So don't think, I'm in perimenopause, I can't get pregnant. You've got sort of these 10 years where you're in perimenopause and you can also still get pregnant. So it's sort of the end of the last eggs coming from your ovaries. So here's some of the symptoms that people may not think about. A lot of times when people think about menopause or perimenopause, they think about, hot flashes, or sometimes they call hot flushes, or night sweats, or, sleeplessness. So that I can't sleep.
Yeah.
I'm kicking off the covers. But here's some symptoms that you may not think about. You may have itchy ears.
Oh.
Why is that? Because your skin may be getting dry, and the skin inside the ears is very fine. That might be your first indication your ears are itchy. You might think you have an allergy, or you might start to develop strange taste in your mouth, or even a frozen shoulder. Seems as if one of your shoulders just doesn't move as well. All of a sudden, none of your deodorants work any longer. It seems as if you have to come and shower in the middle of the day. You're no longer fresh. You have a drawer full of deodorants. If you've noticed that your deodorants are piling up in your drawer because you're trying one brand after the next, you might be in perimenopause. And all of those things are changes. Palpitations, which is often what will bring you to the attention of the cardiologist, who probably doesn't know a lot about perimenopause or menopause and sends you off for a really expensive cardiac workup that's negative. And then they don't know what to do, right? We put you on a type of medication called a calcium channel blocker, a beta blocker, to control your palpitations. But the fact of the matter is, palpitations are related to your estrogen levels decreasing. So you can have any myriad of symptoms. The same skin that is thinning inside of your ears, also thinning in your vagina as well. And it could be that sex starts to become painful because the lining of your vagina is also becoming thinner. And that can easily be managed by estrogen suppositories, either creams or tablets. And it's not systemically absorbed, meaning it doesn't go through your whole body. It stays local, but gives some pliability back to your vaginal walls as your estrogen levels drop. So there are any number of symptoms. Think about vertigo. Are you suddenly sometimes dizzy and the room is spinning? Or do you march confidently into a room to get something only to freeze and not remember why you're there?
That's my whole life.
And
Jayne.
is that happening? There's a little bit of brain fog. All of that starts to be perimenopause. And then you leave the room, and then a minute later you remember it and you go back. Those are all symptoms of perimenopause. There are actually 84 symptoms. So it's not all about hot flashes and night sweats and sleeplessness, although those are important from a cardiologist perspective. And here's something that most cardiologists don't know. The number of hot flashes that you have actually relates to an increased risk of stroke.
Oh.
So the more hot flashes and the greater duration, the higher your risk of stroke. That data was presented at the American College of Cardiology conference just this year in March or April of 2024. We know that sleeplessness without menopause or perimenopause increases your risk of heart disease. Duration of sleep, you need to have at least 5 hours of uninterrupted sleep, but also regularity of sleep. Both of those things can either increase or decrease your risk of heart disease depending on whether you're getting enough sleep or not. And what happens in menopause? We have sleeplessness. So now we have hot flashes. We have sleeplessness. And estrogen is not just in our ovaries and in our reproductive system. It's in our heart. We have estrogen receptors in our heart. We have estrogen receptors all over our bodies. They are also in our arteries. So as our estrogen levels drop, our arteries become stiffer, like less compliant. They're not malleable. And as they stiffen, your blood pressure goes up. So you might start to have high blood pressure during perimenopause and menopause. And then cholesterol and estrogen, both are metabolized in the liver. And so what happens as your estrogen levels drop? Your cholesterol levels may increase as well. So now you maybe have high cholesterol, high blood pressure, sleeplessness. Oh, and just for fun, you may start to gain weight around the middle. We call that visceral fat because your metabolism is changing. And because you're losing estrogen and testosterone, your fat is being redistributed. And because that fat is in the middle, that is active fat. That's metabolically active. And so that fat can also be encasing your organs inside. And so that is a risk for heart disease. So all of these things are risk for heart disease.
Yeah.
All by themselves. And then during menopause, they start to happen all at once.
Yeah.
So of course you've got an increased risk.
Hearing all of that, and growing up, you heard all these things about menopause, of hot flashes and stuff, and it just seems like something that women are expected to suffer through. Are there ways to manage these symptoms?
Or it's a funny, people laugh. Ha ha ha.
Yeah,
ha,
can
ha.
we actually do stuff to manage these symptoms, or is this something that we're just stuck with?
We can. Yeah, we are not stuck. But here we go, back to clinical trials. So let's talk about hormone replacement therapy, because all of these symptoms are being caused because our hormone levels are decreasing. And we know that estrogen not only has a direct cardioprotective effect on the heart by binding to those receptors, estrogen is also an anti-inflammatory agent. And chronic inflammation of the body increases your risk of heart disease. That's why processed foods are bad, because they cause chronic inflammation of the body. So it's not just about weight gain, it's that inflammatory process that creates the plaques along the arteries of your heart and can increase your risk for heart disease. And so all of these things are important. And so if you're not interested in taking hormone replacement therapy, what I want to say about it is many people are reluctant to take hormone replacement therapy. Why? Because we don't have any data on it. We actually do, but we have a paucity of data. And now we go back to the beginning of my conversation. Why don't we have data? Because we don't do research. We don't include women on clinical trials. So it's just one thing after the next. And so then it's difficult for us to manage something like menopause because we don't have any data on it. So then when people start to talk to you about hormone replacement therapy, some people are all in. Some people say, no, I don't want to do it. And then we don't have those big randomized clinical trials to look at. But what can we do? We look at observational data, which is not necessarily the best, but we also look at the information we have, just like the information I just told you. How do we know estrogen works on the body? What do we know are its end effects? How does it work? What does testosterone do? What are the effects of aging? And that's important as well with the testosterone in our bones and our muscle mass, right? You start to shrink and you get frailer. That frailty, called a frailty index, actually determines your quality of life and also whether or not you will have injuries and other bad outcomes as you age without those hormones. And then what else do we have? Drug companies have come out with medications that control the symptoms. They're not hormones. So you're not going to get, perhaps that protection of the heart by replacing your hormones. But if you're not comfortable with hormones, then there are drugs that are available. There are 2 or 3 different drugs that can actually control those symptoms. Now, again, because we don't do research on women, what we don't know is if by controlling those symptoms, we can actually decrease your risk of heart disease. Remember, the data showed that if you have 6 or more hot flashes per week, by the way, that's a very small number. Many times people have 6 or more per hour. But let's just say the data that they looked at 6 per week. The more hot flashes you had, the higher your risk of stroke. So if you take these medications that are controlling the symptoms, but not actually replacing the hormones, which are really the problem, but are controlling the symptoms, does that decrease your risk of stroke? We don't know the answer.
We don't know. Oh, Dr. Jayne, you've my jaw's on the floor because I'm like, holy cow, this is such a travesty to women that we do not have this information.
We don't. But hey, here's the message to women. There is nothing wrong with feeling better.
Yeah.
You, just as you said, Joanne, suffer this, suffer that. We should not have to suffer. So you don't have to suffer through anything. It's not part of the lexicon that is just a foregone conclusion. So even without having that data on our long-term health impacts, there's really nothing wrong with just feeling better, putting your best foot and your best face forward every day and feeling like your normal self. So do not feel ashamed or reluctant to do something that simply makes you feel better. There's nothing wrong with that.
That is a great message, a great message for everyone to take into their hearts and just hear. There's nothing wrong with doing something that just makes you feel better. And with that, what is one action step that you want people to take with them after watching this?
One action step. I would say, as an action step, make certain that you are able to understand the different symptoms of perimenopause, to be able to navigate that in a way that makes you feel comfortable, and that you understand the risks of heart disease and don't accept no from the medical establishment, including physicians. You know that your risk of heart disease is increased. Make certain that you take care of yourself. Make certain that you take your symptoms seriously. And if your doctor is not taking your symptoms seriously, don't be afraid to change doctors and move on until you find someone with whom you can have that conversation, who hears you and who sees you.
Yes. And you have a focus on women's health on social media and your Stairwell Chronicles. Tell us about that and where they can find you for that.
So you guys can find me on Instagram and LinkedIn. I'm at Dr. Jayne Morgan, DrJayne. There's a Y in my first name, Jayne, Jayne Morgan, Morgan. And on Wednesdays, generally, I post a Stairwell Chronicle. So I'll post one tomorrow. I sit on the steps of my house. That's my house. Those are my steps. I'm wearing my clothes. That's literally me. And for 60 seconds, I talk about something regarding health. It's not always women's health. It's not always menopause, but they are little tidbits always about health, medicine, and science. And I do it in a very relatable format in 60 seconds or less. It's just 1 minute of your time. Listen to me talk on the stairs. You can go on about your day with that little nugget of health. Every Wednesday, come back. I'll give you another Stairwell Chronicle.
I love it. You've given us so much great information today, Dr. Jayne. Thank you so much for being here and sharing this all with us. And for everybody, take that action step that Dr. Jayne said. Go and make sure you know those effects of perimenopause and also your risk for heart disease as well. And thank you. It has been a privilege to talk with you.
Thank you. I appreciate it. Thanks, Joanne.
So I am still just floored by everything that Dr. Jayne had to say. It is completely going to change how I am going to continue on this journey for my health. Because again, I didn't know that by dealing with just going I can deal with it. That was going to be possibly causing so much damage to my heart.
Yeah, how estrogen affects the heart. When she said that, I'm like, sign me up for some hormone replacement. I'll be there.
Yeah, no kidding, man. I'll slap that stuff on me everywhere. So, so I know that sounds a little weird, but if you really enjoyed this presentation with Dr. Jayne Morgan, then you have to come to our Happy Mom Summit. Guys, this is our 4th year. This summit attracts thousands of moms from across the world. Well, first of all, it's free. I mean, you can't beat the price point. Yeah.
You get to like meet everyone in there. But if you want like a little extra, right after you register for your free ticket, you do have the chance to buy our VIP pass. It's the cheapest one you can get. You get access to all the presentations right now. You don't even have to wait until the summit starts. And we have over $3,000 worth of speaker bonuses. Like our speakers have donated their programs to the Happy Mom Summit VIP pass. So you can get in their programs for free just by getting a VIP pass. It's really like the best thing around. So go to happymomsummit.com and at least sign up for your free ticket.
Yes. We want to see you guys there. We're going to have fun. It is from March 3rd to March 7th, all virtual. You can wear your favorite sweats, no makeup, and just chill.
So remember, the best mom's a happy mom. Take care of you, and we'll talk to you later.
Thanks for stopping by.
If you'd like to support the show further, you can share episodes with your loved ones, leave a positive review, or follow us on social media at No Guilt Mom. You could also show your love by visiting our amazing podcast sponsors. We have a link in the show notes.
Are you overwhelmed by the things that get in the way of you doing what you want to do? Are you looking for ways to simplify life to better align with your values? Do you want to create space in your schedule so you have room for more of the good stuff? Play, joy, relationships, gratitude, and more? If you answered yes to any of these questions, I invite you to check out Edit Your Life, a podcast to help you edit the unnecessary from your life so you have more room to enjoy the awesome. Through episodes with me, Christine Coe, and a range of super smart, compassionate, and thoughtful guests, you'll come away with big picture insights and practical ways to declutter your home, schedule, and mental space without getting bogged down by perfection. I have always believed that small moments and actions matter tremendously. My goal is to help you find agency and space in your life through doable baby steps that will leave you feeling accomplished instead of overwhelmed. Check out Edit Your Life wherever you enjoy your podcasts.